This is Abby Church. Good morning, everyone. I'm the manager of IHCDA's Homeless Health Infectious Disease Program, and with me on the call are the two HHID outreach analysts, Jesse Van Hoosier and Abigail Kornberger. Abigail covers agencies from Highway I-70 to the northernmost portion of the state, and Jesse covers agencies and partners in the southernmost portion of the state. Today, we will be discussing our recently developed respiratory guidance for congregate living shelters. Homeless shelters have acted on the front lines during the COVID-19 pandemic and are always on the front lines during any subsequent disease outbreaks. We wanted to say thank you for that, and we wanted to express our gratitude to you. Agencies are uniquely qualified to inform epidemic outbreak risk mitigation for the specific needs of people experiencing homelessness. Please review and adopt any section of the guidance you wish for what works best for you in your agency. And you, as you are the subject matter expert, you know exactly what works for you in your agency. The following guidance actually strives to aid agencies in establishing feasible infection control measures, monitoring respiratory viruses in circulation, communicating vaccine information to residents, and it is important to continuously monitor the measures currently in place to control the spread of additional respiratory illnesses in circulation, as well as the available vaccines as new vaccines are being developed and come onto the market. Illness Guidelines, Congregate Living Settings combines the most current Centers for Disease Control and Prevention guidance for mitigating respiratory illness spread in congregate living settings. Because of the close proximity of residents in homeless shelters, the risk of respiratory illness transmission is higher in these settings compared to the general population. A higher prevalence of underlying or pre-existing health conditions produces an increased risk of severe outcome of a respiratory illness infection among this population. Transmission mitigation efforts will look differently in a congregate living setting than measures we would take at home or in a healthcare setting. The following respiratory illness webinar and guidance will provide staff a framework to assess their facility's specific risk of respiratory illness spread, define everyday prevention measures and enhance prevention measures, and update quarantine and isolation guidance, and provide additional resources. The HHID team will update the respiratory illness guidance, congregate living settings guidance, as the CDC continues to update recommended procedures in these slides. This actually does pertain to our presentation today. The CDC actually updated respiratory illness guidance at the beginning of March, and so this guidance in this webinar will be updated to reflect those guidelines. And now I will pass to Abigail.
Let's start with a general introduction to respiratory season. Respiratory season varies slightly region to region, but is considered to be the period of time between October and February, with peaks in activity beginning in December. There are a number of respiratory viruses in circulation during this period of time. These viruses may produce a similar set of initial symptoms. I want to introduce the term influenza-like illness, or ILI, next. ILI is a term used to describe a non-specific respiratory illness categorized by a set group of symptoms. These symptoms include a fever, 100 degrees 0.4 or higher, cough, and or a sore throat. The graphic on the right highlights the situations that might represent an ILI case. These may include a case of flu that has not yet been confirmed with a flu test, an individual who presents 2 or 3 of these symptoms, fever, cough, and or sore throat, an unconfirmed case of a different respiratory illness that has not yet been confirmed with a test, that is not a flu test, so did not produce a positive flu test result. I want to highlight that the ILI category is defined by the symptoms an individual presents. This is a term used to describe the respiratory illness a symptom an individual may have before or if a test to identify the illness is not available. We will go over a quick respiratory symptom identification tool on the next slide. This guide was created as an aid for homeless service agencies to identify the symptoms of a possible respiratory illness of their residents without confusing the symptoms of those that an individual may experience with allergy season, as respiratory season and allergy season overlap. The respiratory illness symptom identification tool includes common symptoms for RSV, ILI, COVID-19, flu, and the seasonal allergies. The symptoms that are highlighted in green are symptoms that fit the ILI criterion. These have been highlighted in green to note the similarity in the initial symptoms of all of these conditions. However, additional symptoms such as sneezing, scratchy throat, headache, and chills may be representative of a condition outside of the broad umbrella of ILI. Agencies may use this guide to quickly identify symptoms and determine the severity of an illness a resident may be experiencing. But this guide should not be used to diagnose a respiratory illness outside of a possible ILI case. Jesse will now cover the next few slides on guidance for prepping for respiratory season as an agency with a congregate living setting.
Thanks, Abigail. Sites serving persons experiencing homelessness and those living in other congregate community living settings play an important role in ensuring the health and well-being of their residents. Medical providers encourage those with respiratory illnesses to stay home, drink plenty of fluids, and rest. People experiencing homelessness are particularly dependent on congregate living settings for rest and recuperation when alternate care sites or respite facilities are unavailable. Facilities are strongly encouraged to adopt and publish a policy to staff for implementation at the beginning of respiratory season. While respiratory illnesses remain in circulation year-round, respiratory illnesses can peak yearly between December and February. The content of a respiratory illness plan should be customized to meet the unique needs of each agency, although it's suggested that the written plans should include instructions for maintaining operations, instructions for reducing the risk of infection among residents, clients, staff, volunteers, and visitors, and lastly, a plan for providing education for residents, clients, staff, and volunteers on how to minimize the transmission of respiratory illnesses within the facility and the importance of receiving the yearly flu vaccine. An important note, 2 or more ill residents with ILI symptoms indicates the presence of a respiratory illness within the facility. If 2 or more ill residents develop ILI symptoms within 72 hours of each other, it may indicate an outbreak of a respiratory illness within the facility. Next, we're going to focus on risk assessment tools. Facilities can consider factors that would indicate heightened risk, including a high volume of outside visitors, poor ventilation, areas where individuals sleep close together, areas where residents' ability to adhere to prevention measures, ability to mask, social distance, self-identify when they are experiencing symptoms, or if a substantial portion of people within the facility are more likely to develop severe illness, i.e., this can be true when residents are considered high risk or have limited access to health care. They should also consider active respiratory illness spread throughout the facility. There are multiple helpful respiratory virus tracking tools listed on this slide at the bottom left that we will be going over more in depth on the next slide. The CDC monitors influenza and ILI across the United States. The FluView weekly report allows individuals to monitor the activity level of influenza and ILI per state. The CDC monitors ILI levels by colored categories, indicating insufficient data, minimal, low, moderate, high, and very high activity levels. The CDC FluView interactive dashboard redirects users to the Indiana Influenza Dashboard established by the Indiana Department of Health, IDOH, when one clicks on the state of Indiana. This dashboard tracks ILI activity, influenza, associated deaths, syndromic percent ILI, and sentinel percent ILI. The CDC monitors several respiratory viruses via the National Respiratory and Enteric Virus Surveillance System. Sites serving persons experiencing homelessness and those in other congregate living settings are encouraged to monitor the trends of respiratory illnesses in their area, tracked by these tools. While the monitoring of these respiratory viruses is essential to monitoring viral seasons and circulation patterns, staff are encouraged to monitor the group of respiratory viruses most likely to circulate throughout their community during the fall and winter months: RSV, flu, ILI, and less commonly tuberculosis, TB, although it poses a high risk of a severe outcome. Respiratory viruses can spread when droplets are inhaled into the lungs or deposited on the mucous membranes of the eyes, nose, or mouth. These droplets are more likely to spread to people who are less than 3 to 6 feet from an infected person who coughs or sneezes into the air. It's believed that droplet spread is the main mode of transmission for most respiratory illness-causing viruses. Respiratory illnesses may also spread when a person touches viral droplets on another person or a surface that has recently been touched by an ill person. Later in the presentation, we will discuss cleaning, sanitizing, and disinfecting to help minimize these occurrences. Everyday prevention measures are intended to be applied at all times, regardless of a suspected or confirmed respiratory illness case within the facility. Agencies are encouraged to ensure hand hygiene supplies are easily accessible. Staff, volunteers, and residents are encouraged to cover coughs and sneezes, wash hands with soap and water, or utilize hand sanitizer when soap and water aren't available. Avoid touching the eyes, nose, and mouth. Avoid or decrease contact with sick persons as much as possible. Recommend all persons who are sick to distance themselves from others when able. Regularly clean and disinfect contact surfaces. And recommend ill staff and volunteers go home at the onset of symptoms. Additionally, encourage the prompt reporting of symptoms that may include a respiratory infection. Punitive disciplinary or administrative actions are discouraged for staff or residents who are reporting respiratory illness symptoms. Once again, 2 or more ill residents with ILI symptoms indicate the presence of a respiratory illness within the facility. This development should trigger the following additional practices in addition to your everyday prevention measures. Firstly, facilities are encouraged to implement daily symptom screening checks for staff and residents. And additionally, enhanced cleaning, sanitizing, and disinfecting is encouraged. Now I'm going to pass it along to Abigail to cover infection control planning within an agency, among other relevant topics.
Thank you. We are now going to transition into a few infection control measures in the case of a confirmed respiratory illness or suspected ILI case. It is recommended that standard precautions to mitigate droplet and contact spread and/or airborne precautions are utilized for ill residents for 7 days after the illness onset or until 24 hours after the resolution of a fever and other respiratory symptoms, whichever is longer. We will discuss the recommended standard precautions for an individual with a suspected ILI case on the next slide. It is important to note that the temperature of a resident should only be measured without the use of a fever-reducing medicine to safely remove the precautions in place. The table on the right highlights the CDC's recommended practices for several respiratory viruses. An individual may not know which respiratory virus may be causing the respiratory illness symptoms they are experiencing. To account for this, it is recommended that agencies follow the standard precautions, which are contact and droplet, for all illnesses that fit the ILI symptom criteria. Agencies may implement further precautions in the case of a sick young child or if an individual may be considered high risk of a severe illness. Individuals who may be at an increased risk of developing a severe respiratory illness case may include individuals over the age of 65, individuals who are pregnant, or if they have a pre-existing or underlying condition. The Respiratory Illness Guidance for Congregate Living Settings document includes a full list of conditions that may increase this risk. We are now going to cover the recommended precautions for suspected and confirmed respiratory illness cases. If the respiratory virus type has been confirmed by a diagnostic test, the following respiratory viruses warrant standard precautions: flu, RSV, and respiratory adenovirus. Additionally, if a resident is presenting symptoms of ILI, fever, cough, and/or sore throat, the standard precautions are recommended as well. It is understood that testing may not be available to confirm the virus type. These precautions act as an umbrella to protect both residents and staff from the known modes of transmission of these respiratory viruses. It is highly encouraged that a resident wears a mask. Encourage ill residents to remain within their rooms or quarantine space where available. The continuation of services is highly recommended for residents who are ill. This may include case management and medical care. PPE reduces the risk of respiratory illness spreading to staff who are interacting with an ill resident directly. Staff are encouraged to mask upon entry to an ill resident's room or when interacting directly with a resident in a shared space. Additionally, staff are encouraged to wear gloves for all interaction involving contact with the ill resident, including when handling their personal. Ill residents only move throughout the agency for necessary purposes. If movement outside of the resident's room or space is needed, encourage the resident to wear a mask and follow respiratory hygiene or cough etiquette. It is important to note that while movement across the agency may be limited, it is still highly recommended that supportive services continue. Lastly, staff are encouraged to provide guidance on how to hand wash, how to use hand sanitizer, and practice respiratory etiquette. These resources will be included in the respiratory illness guidelines for congregate living settings document developed by our team. I want to highlight that isolation measures are recommended only for confirmed respiratory illness cases. Individuals who have tested positive for the same respiratory illness can be isolated together. However, residents with one respiratory illness cannot be safely isolated with another resident with a different respiratory illness. Example being, a resident who has tested positive for flu should not isolate in close quarters with a resident who has tested positive for COVID-19. If a shared space or a singular room is being utilized for isolation in this scenario, staff are encouraged to ensure that there is 6 feet distance between these residents with 2 different virus types. Staff are encouraged to refer to the ideal to least ideal isolation guide for further guidance on isolating in a single room or a large shared space. Quarantine measures are recommended for suspected respiratory illness cases that are not otherwise confirmed with a rapid at-home or laboratory-based test. It is recommended that residents with suspected ILI cases quarantine. Note that quarantine may look like a resident residing within an individual room, either alone or with others who may also have ILI symptoms. Quarantine space could be a shared isolation and quarantine space. It is important that if a shared space is being utilized for isolation and quarantine, that there is distance created between those in isolation and quarantine. Agencies are encouraged to utilize accordion walls, sheets, and 6-foot distance to distinguish between these 2 groups. Without proper measures in place, an individual in isolation, meaning they have tested positive for a respiratory illness, may infect a resident who may have not. We will touch on a few additional airborne precautions for known or suspected COVID-19 and tuberculosis TB infections. Once again, we want to highly encourage the resident to wear a mask. Quarantine is recommended for suspected cases while they await an opportunity for testing, and isolation for confirmed cases. The ideal to least ideal isolation quick guide can act as an aid to staff who are considering infection risk to other residents and other available alternatives. Staff members who are engaging with an ill resident directly or who are entering their space or room are encouraged to wear an N95 or KN95 mask. Lastly, it is recommended that staff encourage ill residents to remain within their rooms or quarantine space where available. The continuation of services is highly recommended for residents who are ill, and that again includes case management and medical care, among others. If movement outside of the resident space is necessary, encourage the resident to follow respiratory and cough etiquette. We have very briefly touched on the precautions for COVID-19 and TB on this slide. For further in-depth guidance and additional tools for mitigating the spread of COVID-19 within your agency, please refer to the HHID COVID-19 guidelines for congregate living settings on the IHCDA website. The HHID team is currently developing further TB guidance for your agency. If you have specific TB concerns in the meantime, please reach out to our email box, hhid@ihcda.in.gov. Otherwise, you'll be notified when the guidance is finalized via email. The precautions we discussed on the prior slide are just one of the measures we can take to protect staff and residents from the respiratory viruses in circulation throughout the season. A multi-pronged approach, everyday prevention measures, standard precautions, respiratory etiquette, hand hygiene, and vaccinations provide the best umbrella to protect the community. Staff can support vaccination efforts by encouraging residents to receive their vaccinations, partnering with state and local health departments to bring vaccination opportunities to your agency, and/or providing clear information about where vaccines are being offered, including time windows and potential cost. We are going to briefly touch on the seasonal flu and new RSV vaccine in this webinar. The flu vaccine changes every year as the variant in circulation during respiratory season changes. For this reason, the CDC recommends that everyone 6 months and older receives the flu vaccine every year to best protect them from a serious case of flu. The routine seasonal flu vaccine is recommended for all staff, volunteers, and residents. A vaccine for RSV is now available. The CDC recommends that adults 60 years and older consider the single dose of the RSV vaccine. RSV can cause illness in individuals of all ages, but can be especially serious for infants and older adults. It is not yet clear if future RSV revaccination will be necessary. The HHID team makes an active call to update respiratory virus vaccine information in this document as the guidance from the CDC changes. A House meeting may act as an opportunity to provide respiratory illness vaccination information and the agency's respiratory illness response plan to as many residents as possible. A vaccination requirement is not recommended for residents. Abby will now cover respiratory and hand hygiene recommendations, as well as a few special considerations for isolation.
Please remember that good hygiene and etiquette practices are important when mitigating respiratory illness. It is important to encourage masking, provide tissues, and encourage clients to cover their mouths when they cough or sneeze, properly dispose of tissues once they've been used, and to wash their hands when they touch their mouths or nose. Additionally, it is important to wash hands throughout the day when using the restroom, before eating, and when an individual has been in contact with a person who is ill. Respiratory illness can and does spread when an infected person breathes out droplets and small particles that contain the respiratory virus. Isolation measures should aim to eliminate or diminish the spread of these droplets and particles between residents who are ill and those who are not. 2, if isolation is possible, please consider this option. 3, create distance between individuals in isolation and the community. Arrange beds so that individuals lie head to toe relative to one another. Create a temporary physical barriers between beds using sheets, curtains, or accordion walls in large shared rooms. Consider whether a room shares direct ventilation with another before using the space for isolation. If multiple residents are ill, these residents can isolate together in the same area. Therefore, suspected and confirmed cases should not be housed within the same space. Staff are encouraged to refer to the ideal to least ideal isolation quick guide when choosing isolation spaces or rooms that are faced with space planning and or resource constraints. We will cover the ideal to least ideal isolation quick guide in a later slide. And now Jesse will tell you about cleaning versus sanitizing versus disinfecting.
The next few slides show some of the various quick guides and graphics that exist in the Respiratory Illness Guidance document. Here we see a simplified visual of the difference between cleaning, sanitizing, and disinfecting. Cleaning removes most types of harmful germs, viruses, bacteria, parasites, or fungi from surfaces. Sanitizer will remove the remaining germs on surfaces after they have been cleaned, and disinfectant can kill harmful germs that remain on surfaces after cleaning. Disinfectant can further reduce the risk of spreading disease. An important note is to always follow manufacturer safety guidelines when using chemical disinfectants. Always clean surfaces first before disinfecting and sanitizing. Impurities like dirt will act as a barrier and inhibit the sanitizer or disinfectant from being able to work effectively. Next, I would like to talk about the ideal to least ideal isolation guide mentioned previously. A few general tips for isolation measures are to create 3 to 6 feet of distance between individuals if able, encourage staff to wear an N95 when providing direct services to clients who are ill, arranging beds so that they alternate directions head to toe, and if able, creating physical barriers between beds. This graphic shows a scale of ideal to least ideal isolation situations. As indicated, the manner in which you isolate can vary by number of total individuals who are ill, as well as the physical location and building or buildings of an agency. The graphic shows that the ideal situation for each quantity of ill individual is in green, and becomes less ideal as you descend down the column. For example, in a situation where only one individual is ill, the ideal circumstance would be to isolate that individual in a separate room. A less ideal situation would be to isolate the ill individual in a shared room with some healthy individuals. And the least ideal scenario would be to isolate in a large shared space. Abigail is now going to discuss making information available to clients.
There are several resident-facing graphics included in the respiratory guidelines for congregate living settings document. These graphics touch on the topics of respiratory hygiene, cough etiquette, and hand sanitizer usage recommendations. These graphics can be used to display new or update previous graphics that may already reside in shared common spaces of your agency. These printable files will be located in the document for your ease of use. I will now send it back over to Abby to wrap up the webinar today.
Reiterating what we have touched on previously, we wanted to highlight a few of the key points from throughout this webinar. First, the continuation of services during health crises is essential. Agencies working with individuals experiencing homelessness should work together to avoid shelter closures or the exclusion of people with symptoms or positive test results from services. Additionally, you can find the full respiratory illness guidance for congregate living settings on the IHCDA website by clicking the link in the orange bubble. If you have a question about county-specific health trends or concerns, or require local information, you can always contact your local health department. Thank you so much for attending the Respiratory Illness and Congregate Living Settings webinar and guidelines release. We want everyone to be aware of our team's email address. Please don't hesitate to reach out to us with questions, comments, or concerns. As a reminder to partnering agencies, please remember we have disease mitigation supplies for order. Also, please also remember that this guidance is intended to be adapted to your agency's unique characteristics. And we are available to help customize this guidance to your specific shelter if you so desire. Thank you again. And at this time, are there any questions? Okay, well, I'm not seeing questions. I'm going to go ahead and end the webinar. Thank you so much and have a lovely day. Bye-bye.